Hi, everybody. So this is an interesting one that we actually had about 2 years ago. And it's a case that I've discussed with people over and over again. It's a type of case that we've discussed over and over again. But I actually had a couple of questions from students. And, a lot of you sometimes message me, especially those who are studying for boards, who are about to write exams. And I've noticed this as a trend, as something that seems to come up from time to time, especially in the oral sections of obstetrics and gynecology and medicine. So, and it's also one of those things that you face in your career that you really need to know how to handle. And it's one of those things that as soon as you see it, it should immediately raise the alarm bells and you should immediately know how to go about doing what you need to do. Okay. So it's not a topic we haven't discussed before. It's not a topic we haven't gone into detail with. And in fact, if you can't remember everything, if you go back through the old lectures, you'll probably find that we've got quite a lot on this topic. I think there's at least 6 or 7 presentations on this particular topic, but I just wanted to present it from this particular point of view. Okay, so away we go. So here we have a 22-year-old female patient. If I remember correctly, it was a second pregnancy. The other baby was born healthy, and she was in the 2 weeks post-cesarean period, or the preperium. All right. So that's up to 6 weeks. It just depends, but normally we say up to 6 weeks post, all right? Which means that she would normally present to a obstetric unit and an OBGYN unit. In our case, she ended up at our unit. We're at Morbidity because we have a sister, mother, and child hospital. We don't get too many of these cases, but we do. And when we do need to know what to do. So she was 2 weeks post-cesarean section, presented with simple shortness of breath and chest pain. She was also tachycardic and low saturations of 74%, and she had been in bed since delivery. Now, this immediately should prompt you to start thinking of one thing and one thing only. So you have a patient presents like this, and they can present in a multitude of manners. Now, in this case, the other thing that you could possibly add to it, let me just add some text over here. You could, for example, add syncope, could be another one, all right? You could, for example, add painful lumps. All right, so painful lumps, especially lower limbs, and it may be unilateral. Okay, so I think I already know what I'm getting at. All right, so it may be unilateral. So these are 2 of the other common presentations that we may get. Okay, and you can also present with other things such as what you might call it, evidence of CVA, TIAs. These can also happen from time to time. So it just depends basically where the patient is having their symptoms from. But essentially what we are talking about here is a pulmonary embolus. Okay, so if we are talking about a pulmonary embolus, the thing that we need to understand is, number one, let's highlight this if we can. All right. We can highlight from here. Not really. Okay. So let's just say shortness of breath. So why does your patient experience shortness of breath? Let's start with that. Okay. Right. So let's put an arrow over here. All right. Just change the color over here a little bit. Let's just put a text box here. So why does your patient experience shortness of breath? The main thing for that is a VQ mismatch. All right. So the question is, what's a VQ mismatch? That's quite simple. That's a perfusion ventilation mismatch. So what's happening in a VQ mismatch? The patient is, let's just change this a little bit. So what happens is that blood, let me put it up properly. Blood enters the lung. Blood enters the lung, but it's unable to reach all areas. Why? Because the embolus is obstructing flow. Right? So that's one of the first reasons. All right. So that's why a patient will experience what you call it a shortness of breath. So as that embolus is obstructing flow, it's also leading to atelectasia, so collapse of the lung. There's decreased perfusion. So once you have decreased perfusion, in order to compensate for that decreased perfusion, you have to now overventilate the other areas of the lung. Understood. Okay. Chest pain. Why do we experience chest pain? I wonder. What is the chest pain associated with? Let's try and see what we can put in here. So the chest pain is for two reasons. Number one, it's lung ischemia, right? So that's the first thing. Okay, lung ischemia, and it tends to be very acute and severe, right? Because you need your lung to function. So it's not necessarily central, which is what a lot of people think, because pulmonary embolism is one of the differential diagnosis for myocardial ischemia, which is central. Now, it's majority of the time it is central. And the reason for that being majority of your emboli that go will end up in one of the bigger veins. And remember your pulmonary artery, because remember your pulmonary artery is actually carrying your non-oxygenated blood. So it generally will jam into one of the bigger ones, but you can have microemboli and you can have emboli that go into smaller areas. So you can even have widespread. So let's say not diffuse, what you say, undiffuse, or so it's not necessarily central and not or may be diffuse. Sorry, not diffuse, may be diffuse. So it can be a diffuse pain that occurs. Okay, so the next one. Let's go to the next one. So why do we have a tachycardia? Let's have a look at that. Oops, I did something there. Sorry. Let me just get pro. So let's go to tachycardia. So why do you think we have a tachycardia? So the tachycardia is for one simple reason, that is catch-up. All right. Now, what do we mean by catch-up? Here we are talking about inflow to the left ventricle. All right. So I've illustrated this quite well in one of our previous discussions. So if you're not 100% sure, just go and have a look at it. Right? So what happens is you have blood that's coming from the right ventricle, flowing up into the pulmonary arteries. From the pulmonary arteries, it's now getting stopped. So the amount of blood that's allowed to come back into your left ventricle is decreased. So your patients will often have hypotension, right, which is a very common finding. It is a cardiogenic hypotension, all right? So they tend to be hypotensive and they have less blood coming in. So how does your body compensate for this? It beats faster so that the amount of blood it's receiving is now is not sufficient in order to continue its function. So it starts increasing its rate. And despite increasing its rate, it may not necessarily be able to keep up with the demands of the body, and you may eventually get hypotension. Now, what's the problem with this as well is that every time it's pumping, the amount of blood that it's sending back into the right ventricle now, starts causing a backup because you can't get as much blood out of the right ventricle. So over a long period of time, if a patient were to remain in an embolic state, they would eventually start decreasing the amount of blood relatively on every step or every beat, and it can lead to a dangerous cycle, right? And of course, your low saturations, again, just tie into this again, a VQ mismatch, right? I don't know how we undid this. Okay, but so I hope that makes a bit of sense. And then let's clear all of that. Right. And the patient had been in bed since delivery. So this is one of the immobility is one of the high markers for pulmonary embolism. Now, of course, you'd look for, you'd want to score it as well. There's quite a few things that you'd want to do. But I mean, just looking at this patient coming in, a 22-year-old female patient, 2 weeks post-delivery, it doesn't have to be post-cesarean section, 2 weeks post-delivery, shortness of breath, chest pain, low sat, syncope, has been in bed, decreased movement, also tachycardia, or even just plain syncope. I remember one lady that we had, and if I remember correctly, it was about 4 months after this patient, and it was a similar story, but her only presenting symptom was that she collapsed in the shower. So she had gotten up, gone to the shower, fell down, came into us. Not to the mother and child, came to us because they didn't think it was pregnancy related. And it ended up being a massive embolus. If I remember correctly, we ended up sending her down to Gray's, which then passed her on to cardiothoracics in in Albert Lutuli, and they actually did an embolectomy. And it was a massive case that was written up because of the size of the embolus that they took up, and they had to put on bypass, and because of the recent pregnancy, and that it was quite an interesting case. So those are the things that you see. So when the patient came in, then an ECG and X-ray was done. So now I'm not going to trouble you guys with going through everything, but let's have a look and see. So what's the first thing that we expect? Now, what we do expect is you've got this heart that's now inflating on the right-hand side because it's unable to push blood through the pulmonary arterial tree, and you have a left side that is now receiving less blood. So the first thing that you would expect is you'd expect your axis to start shifting towards the right. Now, I'm not going to draw everything here, but if we look at this, and for those of you who have been paying attention in the ECG lectures, which this is not, which is why I'm not going through it like an ECG, you would actually start to see that this is now starting to shift towards AVF. So it's just, at the moment, it's just a right-sided bordering on normal, but it's starting to shift towards the right. And where we can see that also is in AVR, it's starting to get a bit of a positive deflection towards the end over there. All right. So you can have a complete or incomplete right bundle branch block, as they're showing over here with the sinus tachycardia. But anyway, let's go through ours. So we have these very slightly peaked P waves, all right, which I think you can see a bit better if you yeah, you've got to look in lead 2, all right? So if you were to look, they're slightly peaked, but not terrible, okay? And we've got this basically a sinus tachycardia that's going on. So if we go from there, but what are the main things that we are looking for? So sinus tachy, complete or incomplete right bundle branch block. So the easiest way to actually remember a right bundle branch block, remember it will be in V1 and V2, and it generally, oh, this is too thick. Okay, let's undo that. Let's make it nice and thin. Okay, so what you would see is your characteristic M shape. Okay. Let's see your M shape like that for a right bundle branch block, all right? Which in most cases, if it's not in most cases, in all cases, if it's greater than 4 small blocks, is a complete, and if it's smaller than that, then it's incomplete. Now in this one here, you can see it a little bit just around there. You can see that typical WM shape that occurs, and that's complete because it's actually actually incomplete. It's not really bigger than the 4 blocks, all right? So right ventricular strain pattern, and T wave inversions in V1 to V4, which does occur. And now this is from that particular patient. So she didn't show all the signs. Right axis deviation was starting to see. R wave dominant in V1, which we're not really seeing. Right atrial enlargement, which again we're not seeing really. This is a common one, S1, Q3, T3. So that means an S wave in lead 1, a Q wave in lead 3, and a flattened or inverted T wave in lead 3 as well. Now in this case, she didn't really have it, and even though it's regarded as a common one, it's not actually that common. So these are the things that you need to look out for. No, don't stress about clockwise rotation, atrial trachyarrhythmias, which can occur. And then, of course, non-specific ST segments. I want you to worry about this one. Now, this is one that we see quite often, even though this patient didn't have it. But in the end, it actually turned out to be multiple microemboli, and that was the reason why she didn't have it. But you have T-wave inversion in the inferiors. In other words, 2, 3, and AVF, you see T-wave inversion, not flattening, T-wave inversion. And then you see that also along the precordial lead. So V1, V2, V3, and V4. All right. So what's the reason for that? Why is that happening? That's what we have to think about. So what is your T wave? So your T wave is a repolarization. All right. So what happens is that electricity is passing into that right ventricle, and that right ventricle is busy depolarizing. All right. So electricity is shooting off throughout the entire thing. Now, when electricity comes back, electricity should be also moving back along that section to be able to get back to the lead, to be able to show it. So the question is, why does it invert? So the question for it inverting is, the reason for it is actually the rotation of the heart because of the increase in the, the shear diameter of the heart. So that's one of the reasons why it occurs, okay? So, but even if you can't remember the reason why, even if you forget all of this and you remember this, I'm very happy. T-wave inversions 2, 3, and AVF, V1 to V4, which is not here. But if it is found, it is 99% specific for a pulmonary embolus. So if you see that, T-wave inversions, 2, 3 AVF, V1, V2, V3, V4. Now remember, this is in the context of a suspected pulmonary embolus. You're not talking about a patient with direct chest trauma, things like, or a patient with left bundle branch blow, with ischemia. So remember that, okay? So that's something to think about. And then, of course, the X-ray was taken. Now, this was the patient's X-ray. Now, in this case, you can actually see what you would call it, the pleural effusion that's occurring over here. You can actually see that there's a decrease in the amount of blood flow into this lung. All right, so she's had what we call oligemia over there. Right, the hemidiaphragm on this side was elevated on the right-hand side. Okay, whereas on the left side, if you compare the two sides, you can actually see the blood flow is much better. But if you look here, you can actually see what looks like a wedge shape opacity starting from there. All right. So and then of course you get something called the Hampton's hump, and there's quite a few other things that go along as well. But in her case, now you can see the wedge shape, which there was another embolus that shot off here, and here you can see the decrease in the blood flow that was occurring in that part of the lung, the pleural effusion, the raised hemidiaphragm. But of course, that can also be due to the liver itself. There was no gastric bubble on this one in that case. And let's look at some other things. So you get wedge shapes. So the wedge shapes are basically telling you that there's an embolus here, and that's become ischemic. All right. Pulmonary opacities, if there's microemboli, in this case, you can't really see it over there. Right. The horizontal linear opacities, which you don't really see to a great extent. The enlarged pulmonary arteries you can make out on this side. That's your pulmonary artery there. So you can see. So in her case, she had quite a large one on the left-hand side, relatively speaking, and multiple small ones on the right-hand side. Okay, so these are the things that we look out for. Okay. So this patient luckily was diagnosed correctly as a pulmonary embolism by the intern and MO in the emergency department. And this was a case that I had to present at a maternal mortality. We have the district M&Ms, and we actually found after we had gone into it, it's quite a delayed response from internal medicine of 6 hours. Now, in their defense, it wasn't their fault. At the time when this patient came in, we didn't have that many doctors on staff, and the doctor was already busy with somebody in ICU. So we came back then, and we after this happened, we actually restructured the protocol to say that if we suspect we need to do thrombolysis in the emergency department, the doctors could discuss with me, and we could go ahead and do it. This was a little while ago. It was just an interesting case, like I say, because of the questions I've been getting recently. At that stage, it was still early in my days at the emergency department, and we actually, had quite strict laws, if I can put that way, or protocols around thrombolysis and all of that. And now it's not as bad. But you may be working in an environment where you may need to thrombolize. You may be in the outskirts. You may not have time to transfer the patient, things like that. And you would use things like streptokinase and alteplase and those types of drugs, which we're not going to get into to a great extent. We've covered them before, okay? And at all costs, you try and avoid maternal mortality, okay? So some of the learning points from here. So you always consider PE, any female patient in the puerperium, so that's up to 6 weeks, and truth be told, even beyond that, right? ECG and chest X-ray can actually provide you with huge amounts of detail, as we saw. So the CT scan just becomes a confirmatory study only, and it tells you the extent of the emboli, the size of the emboli, how many emboli, things like that. But it doesn't necessarily have to become a diagnostic study. You don't have to diagnose a pulmonary embolism via the CT scan, all right? So, and in our case now, if departments are responding poorly, then you have to communicate it to seniors in your emergency department. Ideally, you want to contain as much maternal mortality as possible. You want to avoid it as much as possible. It's one of the markers of our health system is neonatal and maternal deaths. And the higher they are, the worse the health system is considered. And districts and hospitals and all these things, this is how they are judged. And it's worldwide. It's not just in South Africa. So always something to think about. Okay. So today I don't have a funny picture to finish off with, but I hope you guys enjoyed it. And hopefully we'll have another one next week. Okay, keep well. Bye. And of course, as always, if you have any questions, and you can always message me. Bye.